solving a painful hip. So I'm coming directly to the causes. So around 17 to 15% of our patients that we are operating are basically having a dissatisfied hip. They may be painful or they may be just dissatisfied. So what are the causes that we see in any hip patient? So basically the causes of any painful hip is basically, first is infectious loosening rather, very common in our country. Second is aseptic loosening. Third common cause is stem impingement. Then we come down to any stress fracture or a periprosthetic fracture. Non-unions of a greater trochanter or any whenever we are doing any post-fracture hip with the shaft of femur, and most a little bit uncommon but inflammatory, that is bursitis, greater trochanter or iliopsoas tendinitis. So how do we go about with this? That is the thing. These are the intrinsic causes and the extrinsic causes. So these are the extrinsic causes that are not directly related to the hip. So lumbar spine or canal stenosis, lumbar disc diseases, peripheral vascular diseases, nerve injuries, sciatic irritations, femoral irritations, or meralgia, paresthetica. Even causalgia can cause a dissatisfied hip post this thing. Metabolic bone diseases is one of the causes if they are missed. So hernia, they can give referred pain to the groin or the buttock, obturated inguinal hernia or obturated hernia, what accordingly that. So basically these causes have to be ruled out if you have to have a patient that has to be satisfied and not give you trouble post-operative. These things have to be ruled out pre-operative. We have to have a very strict protocol. So 99% specifically, majorly the lumbar spine has to be assessed clearly. Majority of the patients with hip pain have some amount of back pain because of the gait and the limb length discrepancies. We have to see these patients recover after once the hip replacement is done. But we have to see that the patient does not have any disc disease or any canal stenosis. That has to be ruled out. Coming down to how do we evaluate it? So evaluation is basically majorly upon three: clinical. Majority of our diagnosis will come on to clinical this thing. Then we come down to the radiological, and finally the blood parameters or aspiration plus thing. Coming down to clinical, we have to decide. So this is the history, that is the most important. So when does the pain start? Does the patient have the pain immediately after surgery? Does he have, there is a pain-free interval after the surgery? That is very important, whether the pain is due on activity, whether it is at rest. It is specifically in cases of aseptic loosening, that is infection. Pain is majorly when the patient immediately after the surgery. Or late infections, you will see the patient has a pain-free interval and then it comes down to later. The duration of pain, that is important. Site, whether the pain is in the buttock, the hips, whether it is in the groin, coming down to the thigh, in stem loosening or stem mismatch. It is around the stress shielding, it is around the thigh region. Clinical examination, physical examination, that is we have to see that the patient whether he has any sinus, whether he has temperature raised around the site to rule out infection post-operative. So we have to confirm our diagnosis further down by the blood test, whatever we do, basically CBC, raised leukocyte count, ESR, CRP. So CRP, ESR, they have to be raised serially, pre-operative and post-operative. ESRs have to be done. I normally make it a point that I do a pre-operative baseline CRP in many of my hip patients. Aspiration of the joint is to be done whenever indicated. Whenever you are having any little bit doubt about infection, you should aspirate the joint, send it for cell count. The cell count is about 3,500. Then accordingly we have to plan. If there is a doubt that whether the pain is because of intra-articular or extra-articular this thing, so you can give an injector local anesthetic inside the near the joint, and if there is relief, then the pain is basically because of the intra-articular cause, and if it is not, it is basically because of the extra-articular cause. CT scans can be used to rule out stress fractures, periprosthetic fractures, and to quantify osteolysis. Sonography helps to rule out bursitis, adductor tears, this thing. Mars MRI can be used specifically to assess soft tissues around the joints and see to rule out infection. So radiology, how does radiology help us? So radiology helps us to rule out aseptic infections, septic infections. So we see loosening around the prosthesis, probable or this thing. I'll tell you the show you the criteria accordingly. Septic loosening, there will be more scalloping, there will be osteolysis if it is clearly seen around the radiology. Even micromotion will be easily found out. Heterotrophic ossification will be seen. Stress shielding, as Dr. Agarwal mentioned, stress shielding will be clearly seen. We see the osteolysis around the lateral aspect of this thing. Tip of the spine effects, you see some so these are the X-rays. Periprosthetic fractures, stress shielding, as I said, around the greater tuberosity and the lesser tuberosity, you see some amount of osteolysis. So implant failures, there is a varus stem, this causes some amount of hip joint, thigh pain. Heterotrophic ossification around the greater trochanter causes huge amount of pain on the gluteal muscles and GT. This is a case where there is infection and loosening in the femoral canal, as well as loosening of the acetabular component. So you can see scalloping, you can see some amount of osteolysis around the muscle, around the femoral stem. So on the X-ray, basically, to rule out infection, we have to always go for serial X-rays. If we have a comparative X-ray over a period of time, if we have a serial X-rays, then we can quantify whether it is loosening or whether it is staying the same. Definite losing is seen when you see a migration of the component of the stem, cement or a cement fracture. Probable loosening if you have a 2 mm or more wide continuous radiolucent gap that is seen in the cement bone interface. And possible loosening if there is a radiolucent line which is at least in the 50 to 100% of the bone cement interface. In those cases, we can say that there is loosening. So whether the loosening is because of sepsis or whether it is because of asepsis reason, does have to be found out either by seeing clinical picture, plus we have to rule it out by doing other investigations, as I said, aspiration and we can even do a Mars artifact reducing Mars MRI to rule out infection. It is a very good tool. So that is the thing. Once we have assessed, basically the take-home message from all this is that all painful total hip replacements should be approached with an open mind. See, once we are operating, we should not say that we are not, this patient will never have infection, I have taken all care. So you have to think, if your patient is having complaints, we have to keep this thing open. We can tell the patient that you might have an infection. We have to be very clear on that. Specifically, even patients with neurological or he has a sciatic or causalgia kind of pain, you have to be clear with the patient that this can happen. There is stretching of the sciatic nerve. We have to keep our mind open and not say, no, nothing is going to happen with this. Thorough history and clinical examination is the key to the diagnosis. Majority of our diagnosis will be coming on through the history and the clinical examination. Surgical option for the treatment should be considered only after coming to a diagnosis. So if we are going in blindly, yes, there is infection, and or if there is, we are saying there is no infection and going in directly, no, we should have a diagnosis that this is infection. We have to treat it in 2 stages. 1 stage, we have to pre-plan properly and then go ahead and treat the patient accordingly. So majority of the cases we can assess accordingly, and that is how we can treat. Thank you, sir.